and we'll start exactly now. Thank you, sir.
Good afternoon, everyone. So I'll be just a minute. I'm trying to. Okay, so good afternoon, everyone. I will be sharing. I hope you can see my slides. Can you?
Yes, sir, we can see your slides.
Okay, so I'll be taking us today on study designs. And so before we start, I'll just ask us a brief question for the next 20 to 30 seconds. Feel free to drop your answers. I will check the answers. So if you were to eliminate one food or a meal, a food item, so that no one will ever eat it again, which food will you decide to ban or to destroy or to eliminate? So what one food do you wish people never eat again? Let me see if I can see the chat box. Fast food, okay. Any other response? Antoniella, fried ripe plantain. My overall best favorite food of all time. Lord have mercy. Junk foods, okay, interesting. Okay, I'm just, okay, it's surprising that some people don't like plantain. Shawarma, okay, noted. Again, one man's meat, they say, is another man's poison. Eba, please. Okay, all right, no more Eba. Okay, maybe I can take one more and then we'll start. Okay, someone else says Gary. No need to apologize. It's fine. We're all different. Okay, so let's move on. Today is it's another new day. It's a new month. We'll be taking another study in our research series, and today's one is a particularly very interesting one, which if you are able to understand, I think it will go a great deal in helping your research career. So let's move on. My screen needs to move. Okay, so let me move on to the next slide. Yeah. So my objectives for this session is that I hope that once we are done with this, we should be able to list what the common epidemiological study designs are. We should be able to describe or discuss study designs and their advantages and disadvantages, and then we should be able to describe a hierarchy of evidence. Yeah. So what are epidemiological study designs? Oh, sorry. Can you see my slides? Yeah.
Yes, sir, we can.
Okay, fine. So I have an illustrative diagram here to just show us the different types of study designs that we're going to be talking about today. So essentially, when you want to conduct studies, it's important that you know what design to use. And it's also important to appreciate the fact that there are different kinds of designs which would answer different types of questions. So if you want to answer a question that has to do with in which you need an experimental study design, you will have to use that. And that's completely different from if all you just want to do is to observe, in which case observational design will be better for that. So in broad terms, we can broadly classify the study designs that we have into the observational and the experimental. For the observational, They could be descriptive or analytic. And I'm going to be talking about each of these different study designs in a little bit more detail, telling us what we need to know about each one, giving us a few examples, and also the limitations or the drawbacks and some of the advantages of each of them. So for observational studies, examples are the case reports, the case series, cross-sectional studies, ecological studies, case control, and cohort studies. So let's move to observational studies. So what exactly are observational studies? So in observational studies, essentially, you as the researcher, you are not intervening. What that means is you are not administering any drug, you are not tampering with the participants, you are not giving an intervention. All you are just doing is observing the natural occurrences as they occur. So all you are doing, and that's why it's called observational, you are just simply observing, as against interventional studies in which you as a researcher, you are directly experimenting with something. So either you are giving a group of individuals a drug to test, and then the other group of individuals, you are giving them something else, and you want to compare what the effects of those two drugs. So in observational studies, all of those things don't come into play. You just simply observe what you see. You observe it, and then having observed, you can either choose to describe, only describe, in which case those are descriptive studies, or you describe and then compare. So when we say compare, we mean analyze. So you may want to, if you remember the last session I had where we talked about research questions, we said there are descriptive questions. So those questions, you just want to describe something that is happening. You just want to describe a phenomenon. So in those cases, you are not trying to test any hypothesis. You are just describing something. So those descriptive questions can be answered with descriptive studies. Okay. Then when you now come to analytic questions, which can be further broken down into the comparative questions or the causal questions, if you remember the last class we had, those ones can be answered with analytic studies. But all in all, these types of studies we are talking about, the descriptive studies and the analytic studies, you could also still classify them under observational studies based on whether or not the researcher is intervening. So when we come to some examples, you get to understand it better, I hope. So let's move to what the descriptive studies talk about. So I'll start with the very simplest one, which is the case report. So case report is a type of observational study. In fact, some people who are not well grounded in research may not really know that a case report is actually a study. And in fact, if you collect a patient and then you have a case, okay, you've collected your patient, you have your history, you have your examination findings. If you write it up, you can write that up as a case report, because what essentially is a case report? A case report is just a detailed report of a single clinical case. So most times, maybe you have found something unusual. You have found a case that you think is interesting. You want, or maybe it's something that people have not really seen before, or maybe it's the first case you are seeing. You may want to write it up. Like maybe if you are in a setting where you don't really have multiple deliveries, and then in your center you have maybe multiple gestation of maybe 6 or 7. You may want to write it up, detailed history, write how the patient presented, all of the interesting things you're interested, all of the interesting things that you think people may want to know. And this is a study that you can use that study to generate certain hypotheses, okay? So it's an important type of study, even though it's at the very, very baseline. It's a very simple study. So a case report is just a presentation of a single clinical case. Now, another observational study, which is also descriptive, is the one we call case series, which is also quite similar to the case report. So what is a case series? A case series is a descriptive report of 2 or more similar cases. So in this case, what you are doing is presenting to your audience multiple cases of a similar condition. An example of this is when HIV newly came up, there were case series of infectious diseases occurring amongst gay homosexual men in a particular region in the United States. And so that was what highlighted people, is something happening here? What exactly is happening here? So that was one of the first series of studies in which people started becoming aware, even before the organism was isolated. So a case series can be a very important study that can point people to either an epidemic or an unusual occurrence. So if you have, maybe you are in an institution and you see 7, 8, 9 funny cases that are quite similar, that is a very, very good material for a case series. So a case series is a descriptive study. You are not comparing or analyzing anything. You are just describing the patterns in these cases. So you are trying to tell us this is how these cases presented. They were all found in this particular location, and the age range of the people who had these conditions was between 6 and 10 years. So just highlight those important features of that interesting condition. So that's also a study. So I'll take the advantages of case report and case series together because they are quite similar. A case series and a case report, they are really quick. Okay, so they're relatively quick studies to conduct, unlike the more advanced studies where you need a whole lot of time, you need a whole lot of resources, you need a whole lot of human efforts. Okay, but in a case, when it comes to case reports and case series, they are relatively quick, they are relatively cheap, and easy to conduct. Another one is that they are suitable for identifying new cases, new conditions, or rare conditions, okay, or unusual presentations. And another very important advantage of case reports and case series is the fact that they provide rich clinical details, like you will not find in some other studies. For instance, if you are doing maybe cross-sectional studies or you are doing case control studies, those are studies that have to do with population groups, okay? So you are not going to have detailed explanation of individual cases, unlike you would have it in a case report or even in a case series. So that's one of the advantages of case reports and case series. So let's look at the drawbacks. Now, one of the important drawbacks is the fact that it's just on its own, so you're not comparing anything. Of course, that goes with all the descriptive studies in which you don't have to analyze. When there are no comparison groups, all you can just do is to generate hypothesis. You can't test any hypothesis, okay? So there's nothing to really compare to say what could be the cause of this. All you can just do is say, okay, possible reasons or possible causes. You can generate some hypotheses, but you cannot test those hypotheses using descriptive studies like case reports and case series. You can't do that, okay? Then another major disadvantage is the fact that it's prone to publication bias. So what do we mean by publication bias? Publication bias is an occurrence in which the researcher tries to publish only things that are interesting, things that are, you are biased towards certain things and against certain things. So if you like some studies, or if you like there are certain things that you are particular about, those are the things you want to publish. Or maybe if you have some interesting findings and some negative findings, you decide, okay, it's the interesting findings I want to publish. So that's what publication bias essentially talks about. So in case reports, case series, in fact, that's what the studies are about. You are publishing only those things that you think are important. I mean, nobody will do a case report of a malaria case, uncomplicated malaria. Nobody wants to, everybody knows about that. There's nothing new, there's nothing really interesting about that. So inherent in case reports and case series is the fact that they are prone to publication bias, all right? Because if you are going to just tell us about only one case, then it has to be something interesting. It has to be something unusual. It has to be something that we as the researchers think will be of interest to the general public. And of course, because it's only one case, it's only one study, or if it's a case series, a series of studies or a series of cases, it's not generalizable. So whatever findings you get from that study is just limited to only that study. Like we said, you can't test any hypothesis with these studies. So anything you are getting is limited to that study and that study alone. So that's for case reports and case series. And if you go online, you will see lots of examples, especially for those who are in the clinicians. These are studies that they really do often, all the time. So if you see an interesting, especially even if, or for surgeons, you could see an interesting presentation of a case. And when you enter the theater, you saw something else. So those are things that would warrant case reports, okay? Case series, when you see multiple of such things, you may want to just write them up. So that's, these are descriptive studies in which there is no comparison group, they are prone to publication bias, and they are not generalizable. So these are some of the drawbacks. Now let's move higher up to another study, which is a descriptive type of observational study, okay? And that's the cross-sectional study. So what is a cross-sectional study? So as the name implies, you know, when you say you are taking a cross-section of something, it's like it's a snapshot of a particular point or a particular place you are taking. A cross-section just highlights that area or that time point. So in cross-sectional study, what happens is that a snapshot of the frequency of a disease or other health-related characteristics is what that study provides for us. So the data on whatever our exposure is or our outcome is collected at a single point in time. So if we are doing a study on, maybe we are saying, if you take a survey of people, maybe you go to your school, you say you want to survey medical students, and you're asking them questions about their feeding habits, their dietary habits, all right? All you are going to get is at that point in time, okay? So you may ask questions about their dietary habits. You may also ask questions about their whether they are obese or not, okay? So at that point in time, you are getting your exposure may be what are their dietary habits, what do they eat and the likes, and your outcome may be what are they obese or not. But because you are taking both at that same point in time, it's a prevalence study. All you can get at best is just the prevalence. So you may get the prevalence of obesity in that population, all right? But if you want to find associations, you may find associations, but those associations you are going to find, they are not associations that from which you can infer what you call causality, because there's nothing that tells you about the time sequence of those events, all right? Because you are taking your data on the participants' exposure and their outcomes at that same point in time. So all it's giving you is that snapshot, all right? So most times these studies, and that's why most times these studies are called prevalence studies. Cross-sectional studies, another name you may see in the literature is prevalence studies, and that's because they give you prevalence. That's the measure of effect you are likely to get in a cross-sectional study. So you can tell what is the prevalence of this condition, okay? Now, we're talking about descriptive studies, but of note, one thing with cross-sectional studies is that they could be either descriptive or analytic. And I'll explain this. They are descriptive when all you aim to do is just to maybe assess the disease burden or just the prevalence of that particular condition. So you have taken information, you have asked them in your questionnaire, or maybe you have even used tools, your research tools. You have checked their weights, you have checked their BMI and found out who is obese, who is not obese. You have gotten that information, right? Then part of your questionnaire, you might have also asked them, like I've said, their dietary history and possible risk factors. So you may now want to find out, are there associations between those possible risk factors and the obesity that they may or may not have. So if you are trying to do that, at that point where you are trying to test a hypothesis, that now becomes an analytic type of cross-sectional study. So anytime you are testing a hypothesis, this is one of the major things you should note. Whenever you are getting associations, you are having p-values, you are using statistical tests of hypothesis. When you start doing those things, you have moved from descriptive to analytic, all right? And that's because if it's a purely descriptive study, you are not testing any hypothesis at that particular point in time. But once you start testing hypotheses, you are giving us p-values, you are giving us associations, then you have moved to the realm of analytic. And another example could be, you could do a prevalence study and you could do it in two different population groups. Maybe you want to compare urban and rural for their prevalence of obesity. So in that case, it's an analytic cross-sectional study because you are taking it at that point in time, but yet there is a comparative element. You are trying to compare two different groups. Okay, so even though it's a prevalence, you can get the prevalence in one group, the prevalence in another group, and now get what we will call the prevalence ratio to compare both of them. All right, so at that point, it becomes an analytic study. So what's important to note is that when you have observational studies, you could, like I said earlier on in one of my early slides, you could decide to just describe, your study could decide to only describe, or it could describe and compare or analyze. When it does that, it switches over to become an analytic study. So let's move on to see in cross-sectional studies, what are some of the advantages and what are some of the disadvantages? Again, cross-sectional study, it's relatively easy to conduct and quick. Now we are saying this relative to other studies that we're going to talk about later on. Okay, so when you compare, for instance, cross-sectional studies with cohort studies, cross-sectional, it's easier to conduct. And that's because you are just taking a single or a population, okay? So you are not following them up over time. So that makes it easy for you. Unlike when you have to take a group of people and take multiple measurements from them. You take at point 1, take after 3 months, take after 6 months and stuff like that, or take at the baseline and take at the end of the study. So that introduces some elements of complexity. But in cross-sectional, you don't have all of that. At one point in time, you just take all of the data you need and that's it. All right. Then another important thing with cross-sectional studies is the fact that multiple outcomes and exposures can be studied. Now think about it. Because you are just doing a survey of a group of people, there are lots of things that you could find out. There are lots of information you could find out. If I'm doing that study I was talking about on obesity and maybe dietary habits, of course, I'm going to have taken their baseline socio-demographic information. So I'll get information about the age distribution in that particular population. That's an exposure. I'll get information about the sex distribution in that population. That's another information on exposure. I will get about all of those things. Then if I'm taking some clinical measurements, I'll also get information on all of that. Then if we move to outcome, depending on what you have decided to study, what's in your study objectives, you can also still get information on multiple outcomes beyond just that obesity that you might have been interested in. All right, so that's one of the advantages you have in cross-sectional studies. And it also has its disadvantages, just like all those that we're talking about. So all of them have their pros and the aspects of events cannot be reliably ascertained. So for instance, if you find out in your study that maybe let's say the prevalence of obesity in that your study was, let's say 40%, and maybe dietary habits, people who okay, like I saw when I gave that first teaser at the beginning, some people said they wanted to do away with fast food, junk foods. So let's say that the proportion of those who consume fast foods is about, let's say, maybe 50 or 60%. Now, if you take a particular individual from that study, what tells you, how are you sure that if there's an association, you found in your study an association between eating of fast food and diabetes? What is it in that study that will tell you that that individual is because of his eating of junk food that he is obese? Are you sure is not a form of reverse causality in which is that those who are obese are more likely to eat junk food? So at that point, you don't even know whether the obesity came before his eating of junk food or the junk food came before, eating of junk food came before the obesity. Unlike if you are doing a study where you take those who consume junk food and then you take those who don't consume junk food, and at that point in time, they don't yet have obesity. You can follow them up. And so when they develop obesity, you can say, oh, this is this. But as you are information on both their exposure to junk food and the outcome of obesity, at that point, you can't reliably for sure tell us which came first. So that's one of the drawbacks of a cross-sectional study. You can't reliably ascertain the time sequence of events. Another major drawback is the fact that all you can see or all you can measure in cross-sectional studies is the prevalence. So you can't get incidence. And just to bring us up to speed, I'm sure you know that prevalence has to do with the number of existing cases of a particular condition, as against incidence, which has to do with the number of new cases. All right. So if we are looking at, let's say, COVID-19 as an entity, and you just take a study at this point in time, you survey everybody in a particular community, all you are going to find is the prevalence of those with COVID-19. Maybe you take their samples at that point in time and check and test them. So all you can find out is the prevalence. But you cannot know how many new cases, because for you to know new cases, they need to first of all be at risk of having the condition. You need to know those who are at risk of having the condition, in which case those who don't yet have the condition, you follow them over time, and then as people start having the condition, you start accounting for those ones. So those, you are now finding the rate at which people are coming down with a particular condition. And so incidence is a very important measure in epidemiology, in research, but you cannot get incidence or incidence rates or incidence ratios from a cross-sectional study. So which is one of the drawbacks of a cross-sectional study. And then another disadvantage is that if the disease or the exposures are rare, then you will need very, very large surveys to be able to study rare diseases or exposures. Now let's look at another one, which is also a descriptive type of study, but can also be analytic, and it's also an observational study. Now, an ecological study is quite different from the others we have been talking about, and what makes it different is that the unit of observation in an ecological study is population, is a population. So in case series, we are looking at individuals, okay, so groups of individuals. In case report is also an individual we are looking at. In cross-sectional study, we are taking information from different individuals. But in ecological studies, what you are looking at is a whole population as a unit. So an example may be, you want to find out how the effect of air pollution in particular communities, all right? So you are not going to take, you use it based on, for you to assess that kind of information, you know that communities are linked when it comes to things like air pollution, all right? So in a particular community, you can get information on that variable. So that's one example. Another example may be if you want to take mortality rates as a whole in a particular population group, in a particular community, and compare with another community. All right. So at that point, you are taking population level variables or population level characteristics and comparing them with each other. So if you are doing that using populations as units rather than individuals, then you are conducting what we call ecological studies. All right. And so these studies, if you are just describing them, if you are just describing without comparing, maybe it's just only one population group you are looking at, then in that case, it's a descriptive type. But if you, like I said, if you need to analyze or compare two different population groups, at that point, it becomes analytic. And most of these studies, they often use routinely collected data from government health records, vital statistics, birth records, and all of that. And that's because those are where you get population level data from. All right. So what are the advantages? Okay, another thing to note in ecological studies, they're also known as correlational studies. So in the literature, you may see it written as ecological correlational studies or just correlational studies or ecological studies. All right. So what are the advantages? Again, ecological studies are relatively cheap and quick to conduct. And the disadvantages are that there is a potential for systematic differences between areas when you are measuring variables. Then there's also another very important drawback. Well, not really a drawback, but it's something that one should watch out for when you are doing ecological studies, and that's what we call ecological fallacy. And so that means, what ecological fallacy means is that you are not at liberty to interpret population level characteristics at individual levels. So if you find out that mortality rates in a population is directly or is associated with let's say levels of air pollution, you can now say that an individual, pick one individual in that study and say that if his own air pollution level is so and so, then that means that his mortality rate is also low or is high. I mean, if you get what I'm trying to say, you can't just take population level characteristics and interpret them at the individual level, because those population level characteristics you have, they take their average values. So taking an individual at random, you are not likely to have that same interpretation as you will have for the population level variables. So if you are doing that, you are committing what is known as ecological fallacy. So it's important to note that if you are conducting ecological studies in which communities or populations are your units of study, then you should be cautious in interpreting. And I see people make some of these mistakes. They start to describe individual level, describe population level variables on the individual level, which is, it doesn't follow. Okay, so I think that's something you need to be very aware of if you are doing or conducting ecological studies. So you can't just take population level interpretations for the individual. So let's quickly move on to the analytic studies. Remember, we said that we have observational and interventional studies, all right, as the two broad groups of study designs. So for observational studies, we put on the one hand that we have analytic, descriptive studies on the one hand, and analytic on the other hand. And we're giving examples of descriptive. We've talked about the case reports, we've talked about the case series, we've talked about cross-sectional studies, which are descriptive but could also be analytic. Then we've talked about ecological, which are also descriptive, but at some points could also be analytic. Now we're going to look at analytic studies. And analytic studies in this case, like I said, when you start comparing or testing hypotheses, then you have reached the realm of analytic studies. So we'll give the common examples of these studies and also talk about what they are used for, what are their advantages, what are their disadvantages. So the first one we're going to look at is the case control studies. I'm sure you must have heard of this over time. Case control studies, and all of that. Now, in case control studies, remember, your exposure and your outcome have occurred before the study starts, all right? So it's not a case where you are taking an individual who is only exposed to something, and you're trying to follow up to see if he will come down with a particular outcome. In this case, everything has occurred, both the exposure, so maybe he's exposed to a particular chemical, or is exposed to a particular behavior, maybe smoking or taking alcohol. So that may be the exposure. Then you may be interested in an outcome, which is, let's say, lung cancer. So in epidemiology, that's one of the very common examples we like to give, smoking and lung cancer. So in a case where the exposure is smoking, people are exposed to smoking, some others are not exposed to smoking. The outcome, lung cancer. Some develop lung cancer, some don't develop lung cancer. In case control studies, all of the people you are looking at, their exposure and their outcome have already occurred. But when you now want to select your participants, your study participants, you select them based on their outcome status. So first you pick those who have your outcome of interest. So now we are assuming our outcome is lung cancer. So you pick those who have the lung cancer, and then you pick your control group, those without lung cancer. So in case control studies, you are starting from your effect and you're moving backwards to the possible causes. So in case control, I can decide, I want to find out what are the risk factors for lung cancer. For me to do that, I will take cases that have lung cancer, and then I will select matched cases, cases that are similar to those cases, but the only difference between them is the fact that they don't have lung cancer. So maybe if I'm taking people who have lung cancer and they are elderly people, I should not now be taking young children as the controls, because if I do that, whatever I'm getting as my result will be confounded by age, because I will not be able to tell whether those people with lung cancer, all right, whether the exposures they had, all right, was as a result of their age, okay, or whether the lung cancer they even had from those exposures was as a result of the age. So age might be related both to the exposure and the outcome. So it's important that when you are picking your controls for case control, they are similar, comparable to your cases, because like they say, you don't compare oranges and apples. You have to compare oranges with oranges. So the only difference between your cases and your controls should be the presence or the absence of that particular outcome of interest. As much as possible, every other thing should be similar. So they should probably be similar ages, similar sex, similar level of education, and the likes. Things that you think may be possible confounding variables. You want to ensure that both your case and your controls are matched for those possible confounding variables. Because if you don't do that, then you are going to have values that cannot be relied on because of the presence of confounders. Now, so let me give an example of some of the questions. So if you want to find out, do HPV infections increase the risk of cervical cancer? Now, there are different ways you may want to do this, okay? So you may want to take people who have HPV infection and take those who don't have HPV infection, follow them up and find out who develops cervical cancer and who does not develop cervical cancer. Well, if you do that, that's not a case control study. We'll come to that. That becomes a cohort study. Remember, one of the things that defines case control is how you select your participants. So you select your participants based on their outcome status. Now, cervical cancer is the outcome we're interested in. So when you've gotten cervical cancer patients, they become your cases. Now you select the controls that are comparable to those cases, but they don't have that disease. So they don't have cervical cancer, but they are possibly similar in other characteristics, either their social demographic characteristics, other clinical characteristics, and the likes. So if you do that, you now start asking them questions based on their history. Okay, do you have a history of, was there any time you were told you had the HPV infections? Or if you can ask them about the symptoms, did you have so, and so? So you ask both groups, those with cervical cancer and those without cervical cancer, and then they will answer you. You will have to now recall, okay, what happened in the past. All right. Another example is the risk of sudden infant death syndrome increased by parents smoking at home? So in this case, we can say that smoking at home, parents smoking will be the exposure, while the outcome we're interested in is sudden infant death syndrome. So now we may want to, in fact, at this point, we'll now want to find out, are we now going to pick families? We'll look for families where they had these conditions of sudden infant death syndrome. All right. They will also look for families that didn't have that. And then we'll now ask questions about the parent smoking status. So we look for parents who had children. Hello? Are we together?
Yes, sir. I can hear you, sir.
Okay, reactive.
Okay. I just got, I thought I was off. So we need to find out. So if you recruit parents who have had sudden infant death syndrome, who had kids that had that, you may want to now start asking them about whether they smoked or not and all of that. So if you do that, that's going to be a case control study. So there are different types of studies or different examples you can think about. Okay. So these are just some of the examples to bring it home. So what are the advantages? Why do we conduct case control studies? One of the important advantages is that because you don't need lots of patients or lots of cases or lots of participants, you don't have to spend so much money. Okay, so it's inexpensive. Also, you're not following people up for a long period of time. And so you don't have to spend as much money as you would have spent if you were to conduct a cohort study. Imagine if, for instance, we had to do something like we take people who we know have HPV infections, then we take those who don't have HPV infections, and then follow them all until people start developing cervical cancer. You know that's going to take a whole long time because some of those disease conditions, they take a long time to develop. So which means you will follow them up for a long time. You're looking at logistic costs, you're looking at your study participants, you're looking at your research team. A whole lot of things goes into play. But case control does not have these challenges. All right. It's also well suited for diseases with long latent periods. Like I've mentioned now, you can't start trying to follow up somebody over a long time. Okay, you can do that, but it's not as ideal. Okay, because sometimes you may have to, it may take a whole long period of time, which you may not afford. Remember that research, many times we are limited in our time, our budget, and our scope. Always remember that. So work within the limits work within those limitations. Again, it requires few subjects. It's also useful to investigate rare diseases, and then you can study multiple etiological factors. So once you have selected your cases and your controls, because you are going to be asking them about their history, so many different things can come up. Okay, so in the process of asking them about their past history, you may eventually find out that not only were they smoking, they were drinking. And then you seem to now find, it seems that those who were drinking also still had these same conditions. So because of that, you have now not only found smoking to be a risk factor, you have now found drinking to be a risk factor. You may also still find different associations with other exposures. So that's what case control studies can help us to do. With case control studies, you are likely to find multiple risk factors or etiological factors within the course of your study. Again, what are these disadvantages that case control studies have? When you talk about case control studies, in fact, one of the first things one should think about is recall bias. And what does recall bias means? It means that people are not likely to remember, they are not likely to recall certain events that happened in times past. But if that just happens like that, that's not a problem. But if those who are able to recall, if there's a difference amongst the cases and the controls in their ability to recall events, then that is recall bias. Let me explain what I mean. Now, those who had a particular condition, maybe those who have cancer, are more likely to recall things. That's because they've had a disease condition now. So they are more likely to recall, oh, I was doing this, I was smoking, but somebody who is absolutely well, who does not have that condition, he may not have that same motivation, or he may not have that need to want to remember deeply or to think deeply into the past to remember events. So those who have the disease condition are more likely to recall better than those who don't have it. And that is introducing a systematic difference between both groups. So that's one very important problem. When people have to start remembering information, remember, it's not information that you yourself as a researcher are trying to actively follow. It's an information the participant wants to remember. It's not easy to remember, but for those who don't have any reason whatsoever to remember it, I mean, they are not going to stress themselves to remember it. So there's that recall bias introduced in case control studies. All right. Another very important problem with case control studies is that how do you select appropriate control groups? Remember, we talked about the fact that your cases and your controls should be similar so that whatever result you have, you can know that is linked to the fact that this person is a case and this person is a control. So if you see that, let's still take the smoking and lung cancer. Maybe you started with lung cancer patients and then you took controls, those without lung cancer. Okay, you want to be sure that any difference you find in, let's say, exposure rates, okay? So maybe those who had, who were exposed to smoking, who smoked a whole lot, were found to have 5 times the, now because it's a case control, its odds ratio will be used. Let's say they were found to have 5 times the odds of lung cancer compared to those who did not smoke. We want to be sure that that result is linked to that alone and not to the fact that there were other confounding factors like age, like location, and all those other things. So your cases and your controls have to be linked, have to be matched, okay? So finding matched controls is always or is usually difficult. It's not as easy as it sounds. It's usually difficult in practice, okay? So that's one of the problems of case control studies. Another problem is the fact that you can't measure incidents in case control studies, all right? Then another thing is what we call survivorship bias. In fact, case control studies it has lots of bias involved in it, and then survivorship bias is one of them. What do you mean by survivorship bias? Now, if you are going to select cases and controls, chances are, of course, you're only going to select cases that are alive. You cannot study somebody who has died, okay? So if you're selecting your cases and your controls, it's cases of lung cancer that are alive that you are going to select. But what tells you that those who died, there's nothing that tells you that they couldn't have had contributed to your study in a way that will be different from what your finding is giving you, okay? So you have introduced what we call survivorship bias. You have eliminated a large group of people who would probably have added more information to your study, those who died from that disease condition. And that's for obvious reasons. You couldn't recruit them for your study. So in case control studies, you're likely to have what we call survivorship bias. And also there's observer bias in case control study where if you are the investigator and you are trying to ask questions and you know that somebody has the case, he has lung cancer, you may want to probe that person more than somebody who does not have lung cancer. So maybe if I'm administering questionnaire to the person and he has lung cancer, I ask him, do you smoke? He says no. Because you know he has lung cancer, I say no. Do you really smoke? He tells you no. I said, okay, have you ever smoked? He says no. You now try to start forcing him to answer yes. That's an observer bias because you just believe that there should be an association between smoking and lung cancer. So you are probing him more than you would have probed him. Maybe if it was just someone if it was a control who did not have lung cancer and you had asked him, do you smoke? He tells you no. You just leave him alone. But somebody who smokes or somebody who has lung cancer, because in your mind you expect that he should have smoked, you now start asking him, probing him deeper. That has introduced an observer bias. So these are some of the problems with case control studies that are now corrected with cohort studies. So in cohort studies, rather than taking people who already have the disease condition, you take it the other way around. Now you start from cause and move to effect. You start from exposure. So now, rather than taking cases of those who have lung cancer and those who don't have lung cancer, you take those who are exposed to smoking. All right. So you take your exposure groups. The first group, do they smoke? Then your controls, those who do not smoke. And then you follow both groups over time to find out, okay, which of them is likely going to develop lung cancer. So this one is the opposite of case control. It moves from cause, possible cause, to effect. So a cohort is just a group of people sharing a common characteristic, which could be demographic characteristics. Maybe you could have an age cohort, people who are of the same age group. You could have a sex cohort, males. You could have behavioral cohorts, those who smoke. There could be geographic cohorts, people who reside in a particular place, or even a temporal cohorts, people who are related by time. So those who live between so and so, between 1990, maybe let's say the Gen Zs and the millennials, you may do. So the Gen Zs can be a cohort. The millennials can be another cohort. It's a time cohort, all right? So in cohort studies, you are following up a cohort of people over time and comparing them, okay, based on their exposure status to see who develops a particular outcome or not. And then cohort studies are typically longitudinal. That means you are following them up, you are taking multiple measurements, 2 or more. So you take a baseline measurement at that first point at the study, and then at the end of the study, or depending on the type of study you may take it multiple times. But what the point is that you are following up individuals from a particular point up to another point in the future. And now typically it's prospective, all right? But based on when you do that study, okay, cohort studies have often been divided into prospective cohort studies and retrospective cohort studies. And sometimes this has been a cause of should I say, misunderstanding among certain persons. But what it simply means is the fact that in prospective studies, the outcome has not yet occurred. So you are the one conducting the study. So I can decide that today I want to conduct a study and see if there is any association between smoking and, let's say brain cancer, for example. That's just a hypothetical study. I want to do that. So I now recruit today those who smoke and those who don't smoke, okay, and follow them up over time. So at the end, if I now start discovering, okay, how many those who smoke, how many develop lung cancer or brain cancer, and those who don't smoke, how many develop brain cancer. And having done that, I will now compare and find out, okay, so what is the risk in one group compared to the risk in the other group, find my risk ratio and say, okay, so those who smoke are 10 times more likely to have brain cancer than those who don't smoke. So I may want to do that. A very popular example is the Framingham Heart Study, which followed a cohort of, in fact, it's still ongoing, has followed a cohort of up to 3 generations as we speak now. So they are following people up. Most of the things we even know about cardiovascular diseases from this study. So they followed up a group of persons over time and finding out what those who eventually come down with heart disease. All right. So they take those who, they follow that cohort of people and find out who came down with heart disease and who did not come down with heart disease. So that's a prospective cohort study. It's also called concurrent cohort study. Now, what now happens in the case of a retrospective cohort study? In a retrospective cohort study, you are still following up patients or following up participants, but you are using records, and that's what defines it. That's what describes it. So your events have happened. So I can decide, I go back in time, all right, check the case records or case books or medical records of those who were admitted in, let's say, the Lassa fever ward between year 2000 and 2000, let's say in year 2000, okay? So I will pick my cases from there, all right? I'll pick my cohorts of participants from there, and then follow them to a time in the future relative to that year 2000, which might be 2024. So I'm following them up from 2020 to 2024, but I am in 2025. So it has happened, but I'm still following them up retrospectively using historical records. And that's why it's called historical cohorts or historical cohort study. So the investigator goes back in time, selecting the study groups from existing records and traces them forward through time. It may be up to the present, or it may be up to a time in the past. All right. Then there's also the one in which you can do that and have a combination. So you follow them from a time past up to the present, and then still follow them up forward into the future. So that's a combination of both the prospective and the retrospective. All right. But the important thing to note is that you are taking multiple measurements from the same participants at the initial start of the study, at the end point, or at multiple time points. That's what makes it a forward-looking or a longitudinal study. But if you are comparing it based on whether or not the events have occurred at the start of your study, that's what defines whether it's a prospective cohort study or a retrospective cohort study. So this is just an example of a retrospective cohort study on COVID-19. You can look at that in the, I gave some of the references at the end. So what are the advantages of cohort study? You can measure incidence. You can get information on multiple outcomes. Okay, so because you are looking at exposures, exposure is what we are starting with. From those exposures, they can develop many things. There's nothing that stops those patients from developing. You may want to study brain cancer, but you eventually find out that it's not only brain cancer this one's developed, they develop lung cancer. Okay, that becomes another outcome that is interesting to note. So you are able to obtain information on multiple outcomes because somebody you are following up over time, nothing says that that person is only what you're interested in, he will come down with. He will naturally come down with different things he's likely to come down with. And so because of that, you'll be able to get some more information as needed. So I'll just rush over in the next 3 to 4 minutes because I see we have reached the top of the hour on the advantages or experimental studies. But before we go to experimental studies, let me just tell some of the disadvantages of cohort studies. It's often time consuming and expensive. There's a possibility of loss to follow up, and it's not suitable for rare outcomes. Okay. Then for experimental studies, now in experimental studies, here the researcher is intervening. So he's not just observing things, but he's directly by himself giving a particular group something to use while another group is denied that stuff. So a very good example is drug trials or clinical trials, in which case some patients are given a particular drug and comparing the effects with those who were not given that drug. So that's a very common example. So those are experimental studies. Okay, so we have there's a randomized control trials, which is the gold standard for studying medical interventions. And the key features are that there's the presence of the intervention arm and the control arm. There's random allocation into study arms, and there is often allocation concealment, and there is blinding. So blinding means you want to make sure that the participants or the researchers or the analysts do not know which group the participants fall into, whether they are the ones taking the treatment or if it's the placebo. All right. So in single blind, the participant is blinded. In double blind, the participant and the researcher is blinded. In triple blind, the participant, the researcher, and the analyst is blinded. In open label, there's no blinding. Everybody knows where they fall into. All right. So there could be clinical trials. There could be field trials. They're quite similar. Field trials are community-based. They're preventive rather than the clinical trials, which is done to test drugs. Randomized control trials are usually the best for inferring causality. And that's because with randomization, you have avoided confounding and lots of bias you will find in other non-experimental studies. Again, with randomized control trials, you can measure disease incidence and prevalence. And also the temporal relationship between exposure and outcome can be well ascertained. But the problem with randomized control trials is that it's ethically difficult to conduct. In fact, you need a whole lot of ethical trainings. You need a whole lot of, you need to make sure that everyone involved in that trial has gone through certain trainings, okay? You must register the trial. There are lots of things involved in randomized controlled trials, okay? There's also the possibility of loss to follow up. It's very time consuming, it's very expensive, and there's also the possibility of publication bias. So having looked at pyramid, you see that from all of these studies we've looked at, we try to follow them based on the least strong to the strongest when it comes to this study design. So case reports, case series, they are the base. Then you move up to case control, case cross-sectional, case control, cohort studies, and then the randomized control trial, which is the gold standard when it comes to medical interventions. Then if you want to still expand it further and look at evidence in general, then you now start looking at in vitro research, which is research outside living organisms, the animal research, then talk of expert opinions or editorials. All of those are below research. They are below things like case series, case reports, okay? Then having looked at all at the top range, randomized control trials, which we said is the gold standard, now we can have systematic reviews, which looks at multiple studies together, and the meta-analysis, which pulls the results of these multiple studies. So with all of these reviews, those become more, they provide more evidence. So those are the highest when it comes to evidence in general. Meta-analysis, then there's the umbrella review, which is a review of reviews. And then having done that, we have the clinical practice guidelines. So because of time, I will just use the remaining time we have to answer questions. If you have questions, I think this would be a good time to ask them. So these are my references. And at this point, I'll just stop here and take our questions. Thank you.
Thank you very much, Dr. Osahon. It has been an insightful 1 hour with you. Thank you for the knowledge that you have shared. So please drop your questions in the chat box. I would like to ask, my first question is, so for our students still in school, because I believe most of the students here are staying in the university of some sort, what kind of research should we start off with? That's my first question. Then my second question is, where do things like narrative review and scoping review fall under in the level of evidence and in relevance? Thank you.
All right, thank you for that question. So as a medical student, most times I know that many of medical students will do cross-sectional studies, okay? And that's because of the ease. That's because of the, if you look at it, remember the advantages we said, it's relatively easy to conduct, it's cheap, it's not as time consuming as the other studies you would like to conduct. So cross-sectional studies are what we will recommend, okay? Case control studies have their technicalities, which may not be, at this point, you may not be able to overcome some of those challenges, okay, especially when you look at representativeness of controls. Those are things, it's not too easy to get, okay? Cohort studies, you need to follow patients up over a long period of time. If you are limited to maybe a 1 year project, that may not be too feasible. So cross-sectional studies, most times, either the descriptive cross-sectional or the analytic cross-sectional studies are usually studies that medical students are likely to do because of their level of complexity. Then randomized control trials, it's not something one person does. In fact, most studies are not things one person does anyway, but randomized control trials specifically, it's something that you need a whole team, okay, to do that. It's very, very technical. You need lots of experience, training, and education to be involved in a randomized control trial. So it's unlikely that medical students will do for their project work a randomized control trial. All right. Then for your second work, for narrative reviews, scoping reviews, reviews generally, they are above. So they fall under the same class as systematic reviews. But systematic reviews are higher because they are more comprehensive and more complex. Okay, narrative reviews and scoping reviews are not as detailed, and they are methodological. It's not as methodologically rigorous as systematic reviews. but they still fall high because you are looking at it's secondary research that pulls together multiple studies. So if it's well done, it falls above the all of these studies, even above the experimental studies, if it's well done. Okay. So reviews generally, whether it's the scoping reviews, systematic reviews, they fall above in the hierarchy of evidence. And it's important to note that they must be well done. So well done systematic reviews, scoping reviews, narrative reviews, they fall high up in the level of evidence.
Thank you, sir. We have a question in chat. What type of research is a quasi-experimental study?
Okay, so a quasi-experimental study is a type of interventional study. Okay, but it's not observational in the sense that you are not just observing things. So a quasi-experimental study it falls in between, but I would prefer to say they are more of experimental studies that have their own drawbacks. In fact, if you look at study designs, the ones I've given us are the common ones, okay? It's not an exhaustive list. You still have things like the non-randomized trials. We still have things like quasi-experimental studies. We still have things like even the nested case control. We still have things like case cohorts. So those are like modifications of these main ones we talked about. Quasi is also like a modification of experimental, but it's more within the experimental line than within the observational. It's something that I think if you read up, there are lots of articles on it. I mean, you'll find some interesting things there to learn about it, but it's a modification. We have lots of modifications of the main study designs in epidemiology. The ones I gave us are the main study designs in epidemiology. Each of them have their different extensions. Yeah.
Thank you very much for the answer, sir. I think I got a bit of context because online I was searching about like research and I saw like I looked for a paper and I saw a quasi-experimental study on research knowledge among medical students. I think they did a sort of like training or some sort, and they did a quasi-experimental study or like a post-analysis of some sort. So somebody hand is raised up. Oluwadamilola, if you have something to say before we end it for today. You have a question. Okay, I think the person's just signed up. Thank you very much, sir, for lecturing us today on study design. I feel like each and every one of us here has gotten one or two, and we have understood this topic, and it will serve as a platform or a pivot for our research journey. Thank you very much for your time. Thank you very much for everybody that could join us today. God bless you.